Um, he is an exquisitely well-trained interventional cardiologist from Boston. I think both at Tufts and at Mass General. Also trained in heart failure. But I can tell you his biggest credential in my mind is when I met with my old mentor at this past TCT up in Boston, Igor Palacios. Igor told me that Carlos is a great guy. And that we are all lucky to have him, and he wanted us to give him a warm welcome. So that's enough for me. I don't know how many of you know Igor, but he's well beloved, one of the fathers of interventional cardiology kind of through the 80s and 90s, and certainly did a lot of work also in the early 2000s. He's retired now, but kind of continues on in an emeritus role over at MGH, and he's just such a great guy. I just have so many fond memories of him. So I thought it'd be fun today to Karthik had asked me to talk about mechanical circulatory support devices. We're all familiar with them, we all use them, but I thought it'd be kind of fun to have a little bit more of a discussion about them, kind of a little bit of a free-ranging talk. So I had invited Carlos to kind of take the pro side. And as those of you know, I'm fairly pro MCS myself. So being the ultimate sophist, I volunteered to take the con side of it. So we'll get started. So Carlos is going to talk for a few minutes, then I will, and then we're going to have Yusuf kind of synthesize everything, give Yusuf the hardest job at the end to make kind of closing remarks. All right, take it away.
Thank you, Sam. Well, good morning, everyone. I'm delighted to be here. And as Karthik had mentioned, I recently joined the faculty. It's funny. So Sam mentioned that we had some common friends in Boston, and before coming down here, I met with them, and they said, "Oh, you have to connect with Sam. He's gonna guide you and make sure things are okay for you." And so I get thrown into the hot seat discussing debating a hot topic and a controversial topic before the cath lab, but happy to do that. I'm just gonna share. So host disable participant screen sharing. Karthik, is that you?
Now you should be able to share.
Okay, so I think I was assigned the topic of mechanical support devices in cardiogenic shock, and mainly trying to be on the pro side of these devices. And full disclosure, I train in both heart failure and interventional cardiology. So MCS is a big part of what you do in your heart failure year, and IC, as you know, it's where we implant those devices. So, but I have nothing to disclose. Other than I'm passionate about this topic, and I took some extra time learning about them. So I think we can all agree that over the past 40 years or so, there's been a sequential and exponential improvement in the treatment of STEMI throughout the world, from intracoronary streptokinase to systemic thrombolytis, door to balloon time, door to and now possible door to unload time in the setting of STEMI. But if we compare that progress to cardiogenic shock, it's been remarkably stagnant over the past 20, 30 years. The only improvement in care was when the shock trial was released in the late 90s. Since then, we haven't made any changes in this in this area of cardiology. But despite that, and you all know that, and you've seen this, the use of these devices throughout the nation has steadily increased over time. As you can see in this temporal trend graph, looking at use of the Impella device over time, peripheral ECMO over time, and interestingly, balloon pump has had a roller coaster ride recently with a decrease in the use after the shock trial was released, the AIDP shock trials. But recently, with the new unit allocation system in the advanced heart failure world, the use of balloon pump has steadily increased. Since given high priority for patients waiting on a balloon pump. But regardless, we haven't made any change in mortality on heart clinical outcomes in these patients, and this has been shown in some randomized clinical trials, as you can see here, with a mortality hovering 50% across the board. Most of these trials were based in Europe, but if we looked at data from the United States, and this is NCDR CAS PCI data, there's been no change at all in mortality in these patients. However, we continue to see them in our hospitals with an increased incidence over time, likely because of the growing heart failure population, early recognition, and so forth. And we all know that cardiogenic shock it's a complex, multisystemic and dynamic process that starts as a pure hemodynamic problem, but that it can quickly become a hemometabolic problem with multi-organ dysfunction and very low likelihood of reversibility once it's stale. And so that brings a couple of issues when studying cardiogenic shock and therefore mechanical support devices, is that there are different etiologies of cardiogenic shock, there are different phenotypes and clinical presentations of cardiogenic shock. Up until recently, there's been lack of consistency in how do we define the severity and the algorithms for use MCS. And the different devices, the technology pretty much outpaced the data in the last 20 years or so. And the ideal mechanical support device will address all of these components of the hemodynamic equation, will increase coronary perfusion, pressure, decreases LV afterload, but very slight increase in LV stroke volume or actual cardiac output, whereas the axial flow pump devices come from technology from LVAD, durable LVADs. They draw blood from the LV, pumps it into the aortic route with increase in cardiac output, decrease in myocardial oxygen requirements and LV wall stress, and significant LV AO uncoupling. ECMO, peripheral cannulated ECMO, increases the circulatory support, but increases as well LV afterload, PA pressures, and eventually RV afterload. And so recently we've learned that shock comes in different flavors and therefore different outcomes. This is data from the contemporary registry, more than 20 hospitals, called the Cardiogenic Shock Working Group, looking at different etiologies of cardiogenic shock and their outcomes. And now we continue to understand that shock related to MI has a higher mortality than shock related to heart failure, likely because these patients are used to high SVRs, low EFs, and hyperperfusion state. But this is important because up until recently, most of the trials will enroll these patients in the same cohort, and they will be stratified with using the same criteria. The SKY stages recently has made, to my perspective, a significant improvement in the understanding of risk stratification in cardiogenic shock, from at-risk to extremis. And importantly, A, B, and C will be patients presenting with shock without any drugs or devices. And the phenotype B will be someone who is normotensive or hypoperfusion. And this is important because most of these patients are presenting to the hospital in the early stages of shock, progressing in the hospital to higher stages of shock. And this is not uncommon. We come in the middle of the night for a STEMI, fix the LAD, patient is a little bit hypertensive or clammy, they go to the unit, they get started on levofed. Later that day, they get on the butamine. Later that day, finally, they get a SWAN, and the next day, they get a device or different type of support. So I think this brings us to the second important issue, the importance of invasive early hemodynamics in these patients. And that's been shown from using the same registry that patients undergoing complete hemodynamic assessment early on presentation will have better outcomes, as you can see in this bar graph, looking at patients who had complete hemodynamic assessment compared to partial or no hemodynamic assessment in both heart failure, MI, and across different SKY stages. And so if I could just draw your attention to this table, looking at no hemodynamic assessment at all, 20–30% of patients on ECMO didn't have any hemodynamic assessment. and this is across the board on etiologies and SCAI stages. So, it's not uncommon to see complex configuration of mechanical circulatory support devices without hemodynamic assessment. So this is like flying blindly and trying to change outcomes without knowing what the actual underlying pathophysiology in this patient. And this is something that brings us to another issue when studying cardiogenic shock, the issue of timing. And this is something that we learned from the advanced heart failure and LVAD medicine. There is a narrow window where these patients will benefit from LVAD therapy, whereas at some point, and this line has been drawn in LVAD medicine using CPETs and hemodynamics, that would be getting an LVAD will be futile, and early on as well will be unnecessary risks. So the question is, can we identify this window in patients presenting with cardiogenic shock to the cath lab? And again, it's different, right? So it's a time-sensitive issue for us in the cath lab, and it's something that needs to happen quickly, where in this patient, it's mostly an outpatient decision-making. And that's something that's been tested in a pragmatic prospective registry by the guys in Detroit in the National Cardiogenic Shock Initiative, where patients were early identified as potential cardiogenic shock. They will go upfront MCS, followed by right heart cath, coronary angiogram, and primary PCI if needed. And this is the first time that system-based practice has changed outcomes in patients presenting with cardiogenic shock MI compared to prior clinical trials, which I'm sure Sam will talk about some of these trials. And so what happens if we look through all those trials? I thought Sam was going to go first. So if we looked at this trial through the new SCAI stages lenses, and you realize, as you all know, AIBP shock trial randomized patients to balloon pump versus medical therapy in primary PCI, and they show no difference in outcomes. But if you looked at the SCAI stages, most of those patients were SCAI stage D and E. Some of them were SCAI stage C, but regardless, they were on the right side of the spectrum. And also, they were randomized to a device that we know doesn't provide significant circulatory support. Similarly, if we looked at the IMPRESS program, the initial trial that they try to develop was in early stages of shock, randomized into Impella versus balloon pump, but they couldn't complete enrollment. And that brings up another issue about this trial, how to randomize and enroll and even consent for this patient. It's been challenging, and it will continue to be challenging. And so they went on 180 degrees and went through the streaming and stage class E. Patients were randomized to balloon pump and Impella. And if you looked at these patients, 100% were under mechanical ventilation. Lactates were double-digit numbers. LFTs were through the roof. So they were already in the hemometabolic refractory stage of shock. And lastly, on Saturday, the ECMO cardiogenic shock trial was released at AHA, looking at early immediate VA ECMO cannulation in the setting of semi-shock compared to conservative therapy, allowing those patients to go on ECMO down the road. And again, these were patients in SCAI stage D and E, and significantly crossover from the early conservative therapy to the peripheral cannulation ECMO. So it was only 120 patients, with almost half of them crossing over to another arm, showing no benefit of doing this strategy. Importantly, for this particular trial, there was no venting strategy, and so it was a sick population, as you all know as well. And now we understand about combining these devices. Now we're combining ECMO with Impella for venting strategies, and this goes back to the concept of LV afterload and in a patient with LV dysfunction requiring possible venting. And this was tested recently looking at the ELSO registry. It's the largest registry in ECMO patients international. And the team at BI looked at this and showed that patients who got randomized to a venting strategy and usually balloon pumps do better compared to those patients that were not randomized to a venting strategy and actually even receiving an Impella device. And so I think what I've tried to convey in this 10-15 minutes is that most of the trials that we have limitations. They enroll patients in the right side of the spectrum of cardiogenic shock, probably already in the refractory period, and shown that there's no benefit there. But that's like testing a parachute and saying that it doesn't work if you open them at low altitudes, right? So I think there's still, and that's without guidance of randomized clinical data, the real world practice has all over the place, right? So devices are being deployed based on operator performance, operator preference, system level preferences, anecdotes, and so forth. And that's the data that we use, because I published from this registry, trying to look at differences of outcomes in these patients, even using high-end statistical analysis like propensity matching. But if I have one of these two subjects that they appear to be the same, and I try to come up with a final answer whether I've made it a change, but honestly, these are two completely different persons. And then I think that's what we're dealing with in cardiogenic shock. And so what I've tried to summarize here is that there's a lot of components in the treatment of cardiogenic shock, not only pre-cath lab, during the cath lab, but after the cath lab. And some of those components are guided by randomized data, like early reperfusion, culprit vessel only versus complete revascularization, and others. Other components of the management are only guided by registry data, and others have no data whatsoever. So there's a lot of work to be done here, and that's why it's important. That's why this concept of the shock team is now important, and it's shown that having multidisciplinary specialty care for patients presenting with cardiogenic shock at the system level has shown improved outcomes, and some teams have a separate team for shock on call. And this is just the tip of the iceberg. We continue to learn a little bit more about shock, MI, shock heart failure, but what about valvular heart disease shock and even patients on LVAD? This is not an uncommon scenario to have someone with severe AS in shock. What do we do? Do we use the same SCAI stages? And how do we treat them? Do we do VAB first? Do we go straight with the valve? At one point it's futile. So I think there's a lot of work to be done. And we're just starting to define to better define cardiogenic shock. And so I think in summary, pumps just pump blood, and decision is what saves lives, and that comes from a team. I don't consider myself pro MCS, but I am pro appropriate patient selection for these devices, and pro hemodynamic assessment early on in cardiogenic shock. And I'm pro system level multidisciplinary teams for management of these patients and data gathering. With that, I'm happy to take any comments or questions, or we can do that at the end after Sam roasts me.
Can you guys see my screen?
Yes, I can.
Okay.
Does anybody have any questions for Carlos before we hand it over to Sam? So Carlos, has there been any analysis, of these prior cardiogenic shock trials by stages of SCAI shock? Whether there's any signal of benefit and lower, and how are the complications stratified by SCAI levels of shock?
Yeah, there's been some ad hoc analysis on these trials trying to put them in the SCAI stages, but the initial SCAI stages had, hemodynamic variables and laboratory variables that were not available for all of those patients. So there's been some validation of the stages, and that's what I said. Most of those trials randomize patients in the far right of the spectrum. And of course, we know these devices bring a different level of complication, vascular access issues, hemolysis, and so forth, and those patients do worse. So clearly, there is a risk of using these devices, but we're still trying to figure out when does the benefit outweigh the risk, right? So I think that's where patient selection comes into play.
And you
Hey, Carlos, sorry.
Yeah, go ahead.
This is Alexandra. Carlos, first of all, nice to meet you and welcome to Yale. I think one of the biggest problems is randomizing these patients. And as you said very nicely in your talk, is that all the trials are on the right side, right, of the severity. So I guess my question to you is, do you think we could randomize in stage A and B? How do we identify these patients? And could we, if we were to repeat a study, a randomized trial where we're looking at balloon pump and the benefit of balloon pump, do you think we can randomize those patients to nothing, right? And what are the criteria that we need to sort of identify to pull those patients into a randomized study?
Yeah, thanks for a great question, Dr. By the way, nice to meet you. A big fan and all that. So yeah, absolutely, and that's been the challenge on studying cardiogenic shock. And I think that the first task was to show that randomizing on the far right of the spectrum doesn't do much, and that's been shown. And so the question is, can we randomize in stages A, B, and C? And is there equipoise, right, to do nothing versus the balloon pump? And if you think about it, stage A is at risk, so not hemodynamic markers of actual cardiogenic shock, and that's been going on. So that's STEMI DTU. So STEMI DTU is ongoing, randomizing 600 patients in. Results will be out next year. Then stages B and C, I think that's where the money is right now for shock, and I know some of these people are looking into that, and that's recovery 4, right? Recovery 4 will be randomizing early stages of shock to Impella balloon pump in these patients. So I think it's coming down the pipe. I just think the first task was to show that the trials that's been done up until recently took patients that were way too sick, not reversible, and so forth. I think the challenge comes when you actually have to consent these patients and talk to the referring providers and tell them, listen, I'm going to get a 14 French sheath and put this patient on an Impella device because their lactate is 2.0. So I think that's where the challenge is, and that's where data comes handy, right? I think if we show that these patients are presenting in stage B and progressing to stage D under our watch, it's something that we can use as an indication that we need data, we need randomization in these patients. So yeah, I think we will start to, or they will start to explore stages A, B, and C in the near future. And whether repeating balloon pumps versus nothing, I'm not sure we can say there's equipoise there at this point. So I don't think that will be. I don't know. I'm not too versed in clinical trial design, but I don't think that will be the first trial that will be designed in this patient. That I don't think so. Did I answer some of your questions?
Yeah. No, I think so. What you're saying is basically the DTU and Recover 3 are going to address those populations, yeah. the early stage. So we should be able to get some results. Yep.
Right.
So what do we have to offer stage D and E patients? And is your opinion that it's futile? And these are the patients that are often rolling in, and for whatever reasons, of course, we won't identify them at earlier stages, but that stage D and E patient will be rolling in.
Yeah, so absolutely. Yeah, absolutely. I mean, all I can say is that data doesn't show that doing all this changed outcomes, right? But it's difficult to just walk away from someone in their 40s presenting in shock, multisystemic dysfunction, and not doing anything. So, but all we can say is that those patients doesn't seem to benefit from these devices. And again, it's more complicated than the device, right? It's what happens after the device, right? It's like, are there algorithms to take care of these patients? Could some of them get infected or get an ICH, bleeding, all that. So I think it's a little bit more complicated than just throwing a device in. So we will have to address each of those bullet points, right? Especially the post-placement algorithm. Sam.
Thank you.
Thanks,
Sam,
Carlos.
your turn.
So thanks, Carlos. I mean, that was a great kind of overview and summary, and I think you're going to fit in well here because I can tell you that in general, Yale as an institution is not a huge utilizer of these devices, especially Impella. We do use them, but compared to some of our colleagues in other parts of the country, I would say that we're far less utilizers. So I can kind of compared MCS to the old Clint Eastwood movie. And I just want to comment that our own Dr. Nagpal has a very striking similar resemblance to Clint Eastwood there. So I just wanted to bring that up real quickly. But Carlos, I think talked a little bit about some of the good and a lot of the unknowns. So as I said, I had the easier job, and I picked this one on purpose. Describing some of the trials, as Carlos alluded to, there really is very little randomized data that supports the use of these devices. I also have no disclosures. As far as the bad goes, we're all familiar with the complications. This was a meta-analysis, I think, of about 10 trials that was published in 2021. If anything, our experience probably is even higher or even worse than this. In this study, 20% had significant bleeding. About 8% had major vascular complications. Depending on how long these devices, this predominantly is Impella, are implanted, obviously your risk of complications go up significantly. The other major problem that we've had with Impellas have been dislodgement and migration. Predominantly hemolysis has been a big issue. We've also had issues with poor support and suction if it's too far in, ventricular tachycardia when it's too far in, and obviously it's the same thing if it comes out. Obviously, it doesn't do you any good there either. A lot of that has to do with nursing care, and it has a lot to do with patient mobility afterwards. But it's difficult, right? I mean, if you place this device femorally, it's not really anchored. A patient moves, they turn a patient. The device is going to move relative to the ventricular outflow tract, and it can be very difficult to get it back in position sometimes. And then there are, of course, ECMO complications. I'm not going to belabor this. We've all seen our share of ECMO complications. And the number that keeps coming up in all of these studies, and even in these trials that Carlos pointed out, I think it's 50%, right? So 30, whether it's in hospital or 30-day mortality, in all these studies, everything seems to be 50% in all these randomized trials or these registries. There's a little discrepancy I'll talk about later on, but I found that fascinating that we really haven't made much of a difference in any of these. And I agree with Carlos that some of it is possibly selecting patients too late, but I don't think that's the only case because a lot of the Impella trials aren't necessarily just performed in only late stage patients. This is one of the slides I found most interesting. This was from a national database of in-hospital mortality among patients with the cardiogenic shock, 16 years, only has data up to 2018. And you can see that basically the mortality, this is obviously, this is adjusted data, but it's all comers, started to drop significantly for unclear reasons between 2004 and 2008. Jepta probably has better insight to this data than I do, but it's not really clear to me why. Impella 2.5 wasn't approved until 2008. Impella CP wasn't approved until 2012. So I don't think this is from balloon pumps. The authors of this article seem to think this was perhaps a change in reporting, that we were more sensitive about how we reported cardiogenic shock. So we actually were reporting a lot sicker population. So that's why the mortality apparently improved. And again, if going back to Carlos's data, the real increase in use of Impella really occurred 2015 on. So maybe you could say that the most recent downward slide in mortality is attributable to mechanical circulatory support. But, you know, the big jump from 55 to 35% or 55 to 40% occurred well before the MCS era. And these are some of the Impella trials that I found very interesting. This was a interesting study. The first one was a retrospective study that they used propensity matching with patients from the Impella the IBP Shock 2 registry, and they matched Impella patients from a database. And basically the mortality was identical. You know, obviously this is retrospective and used propensity matching, but there was really no difference in mortality. Again, somewhere mortality around 50%. The ISAR shock trial was a randomized trial, very small, 25 patients with acute MI-related cardiogenic shock randomized between IABP and Impella 2.5. The primary endpoint was actually improvement in cardiac index, which is not surprising in favor of the Impella device. But again, the mortality was identical in both arms. Obviously, extremely small trial. These are the problems that Carlos pointed out with these randomized studies. It's very difficult to enroll patients. There have been several studies that have tried to enroll patients, and most of them have actually been discontinued because of failure to enroll over a 5-year period. As Carlos said, the IMPRESS study, similar thing. They tried to, their target was something like 160. They were only able to get 48 patients within the first, I think, 3 years, and they basically decided to terminate the study. And again, 30-day mortality randomized between IABP and Impella CP was almost identical at 50% versus 46%. We're all probably familiar with this article from Amin et al. Included obviously Nihar and Jeptha on it as well. And this was kind of a real world use of Impella and what the current utilization is like and its outcomes. This basically just looked at patients across a wide spectrum, and the Impella usage dramatically increased, increasing threefold over a span of about 10 years. And what they found looking at the outcomes retrospectively was that adverse outcomes and costs were higher in the Impella era, and that Impella use was actually associated with a higher risk of death significantly, 1.24 odds ratio. Bleeding and stroke were also higher. AKI was not significantly higher, but obviously in a non-randomized retrospective fashion, concerning. And you know, the study had criticism because of all those factors, but still, I think it's a warning signal that there's something going on here and that we need to take a look at this a bit further. What about, the other big use of Impella is in what we call protected PCI. That's what Abbott likes to call it. Abiomed, sorry, likes to call it. And this was basically the landmark Protect 2 study. And in this study, again, this was, if you guys remember, this was IABP versus Impella in patients with low EF and high risk PCI. 30-day mortality was not different, actually a little bit higher in the Impella group. And there was a trend towards improvement at 30 days, which was actually magnified at 90 days towards improvement with Impella, but again, not statistically significant. And the composite endpoint had a lot of components to it. Those were all the components in the composite endpoint. So again, not really clear how much benefit there is to routine use of Impella versus IABP. Protect 4 is underway. This, I think, will answer some questions for us. Getting to Dr. Lansky's point, again, this is in the high-risk PCI population, but it's basically randomizing Impella CP versus no planned MCS. If this trial is not positive, then I think it really bodes poorly, because it's not even randomizing to IABP, it's randomizing to nothing. Obviously, I don't know the details of the trial. I don't know if bailout use is allowed. Carlos might know better than I do, but the way the study design is being implemented, it certainly seems to be stacked in favor of Impella. And what about ECMO? Randomized data here are still lacking. As Carlos pointed out, the ECMO CS trial was just released, and it basically randomized 122 patients. 5 were excluded, and basically it wasn't ECMO versus not ECMO. It was ECMO upfront versus initial conservative therapy. And as Carlos pointed out, it was a heterogeneous population, so it's tough to draw firm conclusions. Again, mortality was unchanged. A little bit favorable outcome was that the severe adverse events was also not significantly different, but as you note, extremely high. 60% of patients had at least one of these events. The Euroshock study, which is a much bigger study, this particular ECMO CS trial was only done in Czechoslovakia, but the Euroshock is underway, and again is a randomized trial of ECMO in patients with shock. So hopefully we'll get some data from that. The last thing I wanted to chat briefly about was for those of you that aren't that familiar with these devices, they're not straightforward devices, especially the Impella. ECMO is fairly straightforward. You put it in, you dial up the number, you get the cardiac output that you want, and you can be confident that that's what it is because they have a flow meter on the cannula, so you can actually detect flow. Impella devices are very finicky. In addition to being position dependent, the amount of support they provide is very afterload dependent. So this is a study of flow rate according to what they call the P level, which is basically the amount of current that goes to the motor across different pressure gradients across the aortic valve. And basically, the higher the pressure gradient, basically meaning the higher your aortic pressure is minus your LVEDP, the less the pump is able to pump because it's purely afterload dependent. So if and the effects are similar. So if someone has a MAP of 60 and a wedge of 30, these devices can actually provide quite a bit of support. But if you actually get their MAPs up to 85, 80, 85, and drop their LVEDP down to 10 to 12, you actually put quite a strain on the pump, and the pump output could drop by as much as 20, 25%. So we have to pay very, very close attention to both afterload and preload in these patients, with Impella especially, and we want to keep the LVEDP on the higher side. Paradoxically, you don't want an LVEDP of 12. You probably want it closer to 18, and basically take it out if it's really getting that low because you're dropping your amount of support. The other issue is that there's a very complex interaction between the device and arterial hemodynamics. I've never been a fan of the Impella console. I've tried to talk to their engineers to try to figure out what exactly they're measuring and how they're measuring it. Basically, the Impella device, the console, the idea of the device is to maintain a constant RPM of the microaxial pump. And basically, depending on the cardiac cycle, it takes more or less power, more or less current to be able to do that. So during diastole, it takes a different amount of power less power than it does at systole because because of the opposite, because of the assist from the left ventricle. So you can measure changes in that, and it's basically estimating cardiac output from that. It's not the flow controller measurement that is telling you what the pump is pumping is actually its best guess at what it's doing. It's not a real actual measured number. It's a calculated number. So this comes from Abiomed itself, but when someone with the Impella off, if they have got a 6-liter cardiac output and you put an Impella 2.5 in, you don't get an output of 8.5, because what happens is you've unloaded the ventricle slightly, so the native cardiac output drops, and then the Impella cardiac output is on top of that. And this is very stylized because you don't actually really know what happens to the native cardiac output. This is just their estimation, because again, you're not actually calculating the flow through the Impella device. It's a calculated measurement. So I'm not really confident in what the Impella controller is telling you. If you really want to know what the total cardiac output is, you need some objective measure, right? So whether it's FIC or thermal cardiac output through a Swan-Ganz catheter. So as Carlos said, having a Swan-Ganz catheter in these patients, I think is very, very important. So those are just some of the pitfalls of the Impella console. But I think Carlos gave a very balanced talk, and I think we all, at the end of the day, I think we're all on the same page that we have these devices available to us. They're very powerful. They also have a lot of complications. I don't think at our institution that we're not over utilizers of this technology. I think Yusuf's really championed a very thoughtful approach to this, doing right heart caths in all the patients who potentially were thinking about using MCS in, and not necessarily using it upfront, but reserving it for hemodynamic deterioration during a case. So Yusuf, I don't know if you want to have any final comments on this.
Yeah, I think I agree with you that we're pretty judicious here and we're pretty thoughtful. I think there probably is on the national level the problem with overutilization, particularly in high-risk PCI. I think that, as I say, we're pretty judicious here. I think I agree with both of you. You're both very balanced. On the con side is mainly that we don't have data, and I think we have to be very cautious about how we interpret the observational data. We saw that with intra-aortic balloon pumps. A balloon pump for MI complicated by cardiogenic shock used to have a class 1 recommendation on the basis of observational data, and it now has a class 3 recommendation after randomized trials. So I think we have to be a little cautious in terms of, applying that observational data and drawing too strong conclusions from it. The other main con that you spoke to is, there are hazards with these devices and there are complications. And even with, best, techniques and trying to be as meticulous as possible, there is a penalty to using an MCS device. You're never going to have a 0%, complication rate for bleeding or for vascular complications using it. And on the pro side, I agree with Carlos. Number one, we need strategies to improve outcomes in cardiogenic shock. So we need to, test that. And the other thing that we don't, discuss as much is there are some cases in terms of, high-risk PCI that cannot be completed without a higher level of hemodynamic support. So it's harder to define that. When we talk about them, I think we know these cases when we see them. It's someone who's got last remaining vessel, you have to do atherectomy, the EF is very low, and the pressures are high. When you have a constellation of all of those factors together, you can't do those cases, without hemodynamic support. I think where there's overutilization is that if you have one adverse factor, people may jump to use an Impella. So, for any unprotected left main or any atherectomy or any low EF case. And I agree with you. I think we're pretty judicious here, but there are, on some cases, that just can't be completed without, and you have to accept the burden of the increased complications that we'll get with them.
It wasn't much of a pro and con debate, so I think I agree. I think we're all on the same page here. So, it's two different topics, right? In the cardiogenic shock, it's a different topic compared to high-risk PCI. Two different talks, right? So I think, and I think just shows something very nicely, Sam, that these are afterload dependent devices. This is all coming from heart failure physiology, right? So LVADs are HQ curves and afterload dependent. So sometimes you pop a device and actually you're not gaining any benefit other than looking for complications. And so I think that's also very, very important. That's why I personally don't see these devices as a PCI device, unless, as Yusuf mentioned, you can get in troubles, there'll be some issues, but other than that, I think these are shock devices.
So at risk of sounding snarky, I think the other study that you didn't show, Sam, was the JAMA one that Nihar and Sankit published. And I think in addition, I think Alexandra published something from Premier that was similar, that had sort of different results or differing results from what Amit Amin had published.
So that was in a high-risk PCI, I think, and Amit had included all comers in his.
So I guess there are challenges to enrolling patients in these randomized trials. But if you've got like a company that is now objectively valued at $16.6 billion, you should be able to throw money at it to show the science of it, right? And that's my fundamental concern with this device, and to a certain extent to the field or at large with MCS, is that the payment is outstripping the science to a large degree. And so we've been, it's been approved for 14, 15 years now. We're still with a total of 74 randomized patients. And that's just kind of doesn't doesn't feel right. There is huge discordance just even within our group in the selection of devices. I think the sooner that we can get the shock team up and running, I think the better. And Carlos, Yusuf, Sam, you guys are sort of holding the flag for the interventional group on that work group. Would be great to have a timeline for when we think that's going to really come into play, or have some firmer recommendations that then we can really remove or eliminate much of the unnecessary variation. So comments on that?
Oh yeah, just a quick comment on the shock team, Jeff. So yes, so we're well aware of that, and we actually we've actually taken this under the wing of one of the PI coordinators. So Samantha Lamarck, under the procedural PI group, is going to help us organize this and get this going. So I don't have a firm timeline for you yet, but I think with Sam's help, we're going to be able to really organize this in a more formal way than we had done previously. So we'll keep you posted.
Hey guys, can I make a quick comment? And you might have already discussed this, and you are alluding to this, but as part of these complex cases and the decision making, from the vascular perspective, it would be good to get your PV doctors involved in some capacity, particularly because of the complications after and/or the removal of these devices. Like, we've been in difficult situations where walking in the middle of someone actively bleeding with an RP bleed, trying to put a cover stent, although we do it and it's straightforward, is a lot easier if we have a plan from the outset. Like Yusuf and I had an extensive conversation about a patient that requires such device up front, and that just put us on the same page, alert each other, plan the scheduling of the procedure for those that are at least elective, and minimizes the potential bad outcomes. Just something to think about.
Yeah, I completely agree with that, because the vast majority of the catastrophic complications that these patients have are vascular, and so if you have a plan going in, then you can avoid these catastrophic outcomes. It's also honestly one of the downsides of the single access technique. We're doing more and more of these cases to avoid a second arterial stick, but then you don't have necessarily something in place to help you bail out at the end. There are ways to bail out, with the single access, but it's not as straightforward as having, contralateral access and going up and over.
Yeah, I couldn't agree more. And I think there's another piece of decision making from the vascular perspective is, who gets an antegrade perfusion catheter, who doesn't, and do you do it before the large sheath, after the large sheath? Leg ischemia is a big one here, but not everybody needs an antegrade perfusion catheter. So that's, I completely agree. I mean, vascular should be part of cardiogenic shock for sure.
So Carlos and Sam, can you explain to me a little bit about the distinction in the SCAI stages, especially C and D? Because you sort of suggested that in D and E, that you guys feel that there's no benefit. Again, it feels horrible because we have all these devices, we have all these interventions and advances in cardiology, and these are the sickest patients, and it just feels that we should be able to help them hopefully in the future. But between C and D, to me, like when I read the classification, it almost seems like the difference is time, right? It's like, because all of the things, if you see, it's like deteriorating renal function, escalating pressures, and or worsening. So all those words like take into factor the time. And on the other hand, we have the camp of early MCS, right? So when a patient comes in, like, can you even call them stage D? Because you're placing the device early, like, because the decision needs to be made there, right? So what is sort of the distinction when a patient presents? How can you call C and D?
That's an excellent question, Karthik. I don't think we really know, right? I mean, I kind of equate it to, New York Heart Association classification for heart failure. One man's 2 is another man's clear 3. The objective criteria are somewhat lacking, and I don't know. I would defer to Carlos, and I'm curious to see what he's going to say about it. But that's the one of the cruxes of the argument is how early is early enough without being too early, as Carlos mentioned. To be honest with you, I think that with the current generation of devices for actual shock, I don't think that they're not good enough devices. I mean, they're the best that we have, so we use them. For protected PCI, they're probably okay. But for true hemodynamic support and cardiogenic shock, I think we need a different device, and something akin to the 5.5 that could deliver more cardiac output. So hopefully the next generation of devices that's on the horizon are going to be able to provide that. They're basically these nitinol devices that expand from a smaller French size to a larger French size and can give you higher cardiac outputs for a short period of time. Unfortunately, they're not as durable. They fall apart, so you have to be careful about how long you have to use them. But for me, looking at the results of these studies, that's what to me it points to, is that the devices that we have just aren't good enough. Carlos?
Yes, I think that's I completely agree, and that's the $1 million question: is how do we consistently define the sky stages across the spectrum? And this came from a expert consensus statement using some clinical variables, some hemodynamic variables, but the granularity of all those definitions are still lacking, right? So I think for example, now we've identified that subset of patients who are the normotensive hypoperfusion patients, meaning normal blood pressure, but the lactate is rising, renal function is getting worse. Those are the sky stages B that maybe benefit from these devices. But making that final call is still tricky, and that's why we need more granular data. And I didn't show all of the data. For example, back in fellowship, we looked at RV function, congestion in patients with normal indexes and normal wedges on support, and show that those patients do worse, right? So maybe having signs of congestion in the setting of systemic congestion in the setting of shock on support, it should be added to those stages as well. And this goes back to the CLINT classification, right? So if you come in with systemic CLINT class 3 or 4, you do worse. And so I think they're still trying to define that, and that's the question. Like, when is that window of appropriateness right for these devices? Because I think we all agree that they come with a price, and I'm not talking about dollars. I'm talking about complications. So I do think that, as you mentioned, late stages, we're still creating the complications and creating the expenditure without any benefit. So I think that we should need to focus as a group of when would these devices be beneficial, right?
Have I remembered correctly that stage D is the stage that they are not improving or worsening despite some form of intervention, whether that's pharmacological or mechanical? Is that the definition of D? Someone who's in shock and not improving?
Yeah, so that's why it adds that element of time. But when we see these patients, they are presenting right there, right? So who is D? If you don't do anything, everybody becomes D.
Yeah,
right?
I agree.
So,
It almost can't be D by definition of presentation. You're either in E because you're in extremis.
Right, that's easy to identify.
Because we haven't tried anything.
Everybody else whom we think about MCS is C, right?
Yeah.
And maybe like what Carlos suggests with evidence of congestion and things like that, we can maybe pick out some of those B's and C's who may benefit, but the large chunk of population who's dying is all this category C, and I hope something in the future will show benefit, because that's the true cardiac emergency, right?
Carlos, great to meet you. We look forward to seeing you around.
Thanks, Sam. Appreciate you having me, and looking forward to meeting you all in person and working together.
All right. Then no other questions. We'll call it a day today. Thanks, Sam. Thanks, Carlos. Thanks, Yusuf. Until next week. Thank you, guys.